Hello everyone. So just confirm me if I'm loud and audible. I understand that there is a little bit of background noise or echo because uh, right now Bangalore is going through stormy weather, so it might bother you a bit. Okay, so what are we up to now? We are running this Reed Harrison series for quite some time and we have covered some major topics. Before we get going with the remaining topics, we are going to do one or two quizzes and then we will get back with the rest of the topics. So today we are not going to take more than 20 or 25 minutes. We will solve 5 important MCQs. The reason we are doing this is because when it comes to the learning, right, the best way to assess whether we have learned something or not is not by asking you to write a prose or a theory, because we all know that we can cook up the answers. But when it comes to objective questions, they test the fundamentals very precisely, right? So what we will do, we will take up the first question now. I'm expecting all of you to give me the correct answers. So here is the question number one. I guess it is a bit pain for you, maybe the typing issue. Anyway, I will read the question for you. So what is the question number one? Simple and straightforward, easy question. The pallor of palmar and plantar creases indicates that the patient's hemoglobin is likely to be. Pallor of palmar and plantar creases indicates that patient hemoglobin is likely to be less than 7 grams per deciliter is the first option, more than 7 grams per deciliter is the second option, less than 10 grams per deciliter is the third, and more than 10 grams per deciliter is the last option. So what do you think is should be the answer? When palmar creases, these crease and plantar crease are as pale as the rest of the skin, we count it as severe anemia. We have learned about the grading of anemia in one of the Reed Harrison series, right? And when you call it a severe pallor or severe anemia, when palmar creases and plantar creases are as pale as the surrounding skin. And that indicates that hemoglobin is less than 7 grams per deciliter. So answer for this question should be option A, hemoglobin less than 7 grams per deciliter. Okay. And why this is an important parameter? Because hemoglobin 7 grams per deciliter is required for sustaining the normal physiological function of our internal organs. If hemoglobin is less than 7, slowly your cardia will bear the burden and you can get into heart failure. Slowly your renal, lungs and brain will also be hypoperfused, or they will not be getting sufficient oxygen, and their function will also start getting deranged. So anemia can affect the functions of vital internal organs. But as long as we maintain the hemoglobin 7 plus, we are on the safe zone. So if you see any patient whose palmar creases are not pigmented like mine, they're as pale as rest of the skin, it means number one, their internal organs are at critical danger. Number two, the only way you can quickly take them out from the danger is by giving the blood transfusion, right? And that is why we count this hemoglobin 7 as the transfusion threshold. Whenever hemoglobin is less than 7 grams per deciliter, we should go for blood transfusion. As long as it is more than 7 grams per deciliter and not dropping, maybe you can manage that anemia with the nutrition or whatever the cause, we can treat it accordingly. Clear? So this is the first question. This is a repeatedly asked MCQ point. Right? We count this as severe pallor or severe anemia. Okay, now here is our second question. A 60-year-old presented with raised JVP. Just give me a second. I will adjust the screen. A 60-year-old presented with raised JVP, hepatomegaly, that is tender, and we heard a pansystolic murmur, auscultation. Okay, so what are the findings? Raised JVP, tender pulsatile hepatomegaly, and pedal edema. Three things. Then auscultation revealed a pansystolic murmur in the right second intercostal space. Sorry, there is a small correction required here. The left second intercostal space near to the sternal border. The murmur increased. I think most of you got it right based on the region, systolic and aortic, but I'm making a small correction. Let us take it as left second intercostal space near the sternal border. The murmur increased in intensity on deep inspiration. What is the likely diagnosis? I'm reminding you again, what are the findings? Elevation in the JVP, right? There is liver which is enlarged, tender and pulsatile, and patient also has pedal edema. So what did we learn when we learned about the approach to a patient with murmur? First thing is, try to see the symptoms, whether the symptoms are suggestive of the dysfunction of the right side of the heart or the dysfunction of the left side of the heart. So now looking at these symptoms, what do you think? This patient has the symptoms suggestive of right heart dysfunction or the left heart dysfunction? Pratisha, right. When hemoglobin is less than 7, it calls for blood transfusion. So these are all suggestive of right heart dysfunction. Absolutely right. These are suggestive of right heart dysfunction. So now what valves we have on the right side of the heart? The pulmonic valve and the tricuspid valve, right? We have the pulmonic valve and the tricuspid valve. Pulmonic and tricuspid valve. Okay. Now, in what condition we can have a pan-systolic murmur on the right side? What all conditions on the right side can give rise to pan-systolic murmur? Okay, forget about pan-systolic murmur. Only tell me about in what all conditions we can have uh, the murmur systolic on the right side of the heart. Systolic murmurs on the because of the right side pathology. Systolic murmurs because of right side. We're talking about right side pathology. Right? Left side pathology would have presented with the dyspnea, orthopnea, and PND. In that case, we would have thought of aortic valve and mitral valve pathologies. This patient is presented with raised JVP, hepatomegaly, and pedal edema. So, what should we suspect? Right heart pathology, either pulmonic valve pathology or tricuspid valve pathology. So, between these two, what all conditions can present with a systolic murmur? Pratisha, right. On the left side, aortic stenosis and mitral regurgitation have systolic murmur. On the right side, the tricuspid regurgitation and pulmonic stenosis. Tricuspid regurgitation and pulmonic stenosis have the systolic murmur. Okay. So, now in this case, what is the possibility that we should think of? Among the two options, what should I think of? Right side, tricuspid regurgitation and pulmonic stenosis can present with systolic murmur. Now, from which area we are better hearing this murmur? From which area we are better hearing the murmur? Left second intercostal space. So what is this area? This is pulmonic area, right? This is pulmonic area or pulmonary area. So this murmur is heard from the pulmonary area. So what does that indicate? Most likely we are having a case of pulmonic stenosis. Pulmonic stenosis. Most cases of pulmonic stenosis will rather present with an ejection systolic murmur, but among the given scenarios, that seems to be the most logical answer. So what is the take home message from this question? Whenever you have a valvular heart disease, first look at the symptoms. See whether it is a right-sided symptom or the left-sided symptom. That will narrow down 50% of your differential diagnosis. After that, look at the area from which the murmur is better heard. That will tell you which valve is most likely affected. In that case, once you know the valve, right, you're left with only two choices. That valve will have one regurgitant lesion and a stenotic lesion. You have to choose between the two. Even a little bit idea about the murmur ki systolic hoga or diastolic hoga will take you to the diagnosis. Okay. Now here is our question number 3. In this question, we have a 60-year-old who presented with recurrent episode of falls and faint-headedness on getting up from sitting position. Okay, what these symptoms are suggestive of? Recurrent episodes of falls and faint-headedness on getting up from sitting position. Whenever you get this history, this is a common history that you will see in OPDs, especially elderly people presenting with this kind of history. थोड़ा सा उठता हूँ तो फिर चक्कर आता है, थोड़ी देर बाद फिर ठीक हो जाता है. What is this suggestive of? So this is suggestive of what we call as orthostatic hypotension. Orthostatic hypotension. In what all conditions we can see orthostatic hypotension? The disorders which affect our autonomic nervous system, like diabetic neuropathy, or certain alpha synucleopathies like Parkinson's disease, Lewy body dementia, then the multisystem atrophy. So these are all alpha synucleinopathies, and diabetic neuropathy is a very common cause. Drugs can also. Okay. Now in this question, they have mentioned that he is a known case of Parkinson disease. Is Parkinson disease an alpha synucleinopathy? Absolutely right. And I think, if I remember correctly, I told you these alpha synucleinopathies are those disorders which alpha synucleinopathies are those disorders which include accumulation of alpha synuclein inside the neurons, and because of that neurodegeneration happens, and they characteristically share one finding which is called as REM behavioral disorder. Under this we have Parkinson disease, we have Lewy body dementia, and we have multi-system atrophy, three disorders, and all of them share a characteristic which is called as REM behavioral disorder. REM behavioral disorder. Okay. I will come back to this point. I want you to understand this point, REM behavioral disorder. So if anybody knows, just drop a comment. Now getting back to the question. The question says, you suspect that patient may be having postural hypotension. Rightly so, because he is a case of Parkinson's disease. So he has alpha synucleinopathy. So that means he has autonomic nervous system dysfunction. So he is prone for postural hypotension. Now we have to confirm whether he has it or not. How do we confirm? We have to record the BP in the sitting or recumbent position and the standing position. Okay, and based on the parameters, we decide the orthostatic hypotension hai ya nahi. Now, what is the question saying? Which of the following ideally describes postural hypotension? Please remember, multiple answers may be correct here. MSA stands for multi-system atrophy. Multi-system atrophy. It is also one of the neurodegenerative disorder. Okay. Now, option A, decrease in systolic BP by more than or equal to 20 millimeters of mercury within 3 minutes of standing. Option B, decrease in systolic BP by more than or equal to 20 millimeters of mercury 3 minutes after standing. Option C, decrease in diastolic BP by more than or equal to 10 millimeters of mercury 3 minutes after standing. And option D, decrease in diastolic BP by more than or equal to 10 millimeters of mercury within 3 minutes of standing. So what all are the right answers here? What all statements make the correct sense here? What do you think? Shubham Gai, absolutely right. Very good. Very good. Okay, so let us go one by one. Statement A, correct or false? A, statement correct or false? So go back to the notes. What did we write there? When should we record the BP after the patient stands? 3 minutes after standing, not within 3 minutes. When we suddenly stand, some degree of systolic drop in BP, diastolic drop in BP is expected because सारा blood तो lower limb में pool हो रहा है. उसके बाद में हमारा ऑटोनॉमिक नर्वस सिस्टम एक्टिवेट होगा, दैट विल मेक द कॉम्पेंसेटरी चेंजेस टू इंक्रीज द बीपी. तो उसके लिए थोड़ा सा टाइम लगता है. बट वंस यू स्टैंड 3 minutes आफ्टर यू हैव स्टूड अप, your BP should be normalized. P, it is less than, like there is 20 millimeters drop from the sitting position or the recumbent position in systolic, or 10 drop in diastolic, we will count it as orthostatic hypotension. So statement A is false. Statement B is true. Statement C is true. And statement D is false. So B and C are the correct statements here. Decrease in systolic by 20 millimeters of mercury 3 minutes after standing, or decrease in diastolic by 10 millimeters of mercury or more 3 minutes after standing. So the word to remember here is after. Please remember this. This is where the MCQs confuses. It is after. Okay. Okay, so what is this REM behavioral disorder? REM behavioral disorder is a disorder typically seen in alpha synucleinopathies. Now, what happens in alpha synucleinopathies is, in these patients, their muscle tone increases. Normally, what happens when we go to sleep, our muscle tone decreases. That is why our hands, body parts will all be hanging in sleep, because the tone is decreased. It is a natural adaptation that nature has done for us, because when we go to sleep, we start dreaming when we enter the REM phase of sleep. when we enter the REM phase of sleep, we start dreaming. And when we are dreaming, actually, like when we are dreaming, our brain is living that moment. It is in that era. So अगर आप ड्रीम में डांस कर रहे हो तो एक्चुअली ब्रेन इज थिंकिंग दैट यू आर डांसिंग. Only thing is that your body is not responding to the signals that brain is sending because the muscle tone is so low that the signals cannot activate the muscles. ये एक नेचुरल अडेप्टेशन है. अदरवाइज जो भी ड्रीम में होता है, we will start doing it, enacting it during the sleep. But in patients with Parkinson's disease or Lewy body dementia or multisystem atrophy, there is increase in the muscle tone. We call that as rigidity. And because of that increased muscle tone, जो भी signal brain भेजेगा during the dream will start putting it out in action. So if in your dream you're dancing, then you're physically also you'll start making those movements because muscle tone sufficient here to do those movements. This is what we call as REM behavioral disorder. So REM phase of sleep में patient starts behaving abnormally. Abnormal क्यों behave कर रहा है? Because he is putting out the dreams into his actions. Okay. Now let's go to the next question. Yeah, exactly. See, normally what happens is the tone during sleep significantly decreases. But if we do not, see, there are only few muscles whose tone does not decrease. Most prominently, you should remember that the eye muscles, the muscles of extraocular movement, its tone does not decrease. That is why what we start dreaming, अगर कुछ scene चल रहा है हमारे आंखों के सामने during dream, our eyeballs will be moving according to that. That is why in REM phase of sleep, rapid eye movement क्यों हो रहा है? क्योंकि जो सपने में चल रहा है उस सीन के मुताबिक हमारे eyeballs इधर उधर मूव कर रहे हैं. उसका टोन डिक्रीज नहीं होता है, तो दे आर रेस्पॉन्डिंग. Rest of the body muscles tone is significantly reduced. There is profound hypotonia during sleep, so they cannot respond. अगर पार्किंसन डिसीज की वजह से टोन इतना इंक्रीज हो गया कि वो रेस्पॉन्ड करने लगेगा, then not only eyeballs but the body parts will also start moving. That is the basic thing. So the Samantha, REM behavioral disorder is a disorder that we see in patients with alpha-synucleinopathies. Alpha-synucleinopathies are like Parkinson's disease, multisystem atrophy, Lewy body dementia. यहाँ पे क्या होता है, पेशेंट्स हैव रिजिडिटी. रिजिडिटी का मतलब क्या है? इंक्रीज इन द मसल टोन. एंड बिकॉज ऑफ द इंक्रीज मसल टोन, उनका मसल टोन जब अवेक होते हैं तो बहुत हाई होता है, स्लीप में कम होता है, लेकिन जितना नॉर्मली कम होना चाहिए उतना नहीं होता है. तो फिर भी हायर ही है ड्यूरिंग स्लीप ऑल्सो. इतना हाई सफिशिएंट होता है फॉर द मसल्स टू मूव इफ ब्रेन सेंड सम सिग्नल. नॉर्मली ड्यूरिंग स्लीप, ड्यूरिंग ड्रीम, brain keeps sending the signals to eye muscles as well as body muscles. Body muscles don't contract क्योंकि उनका टोन बहुत कम हुआ होता है. सिर्फ आई मसल का कम नहीं हुआ होता है, तो आई मसल्स रेस्पॉन्ड टू इट, इसलिए आई मूवमेंट होता है, रैपिड आई मूवमेंट फेज ऑफ स्लीप में. बट अगर बॉडी मसल्स का भी टोन ज्यादा है तो दे विल ऑल्सो स्टार्ट रेस्पॉन्डिंग एंड द पेशेंट स्टार्ट मेकिंग द मूवमेंट्स दैट ही इज ड्रीमिंग. सो इन द ड्रीम इफ ही इज बॉक्सिंग, ही विल स्टार्ट बॉक्सिंग. And because of that, yeah, patient himself and even the patient partners can get injured. And this is what we call as REM behavioral disorder. Okay. Now this question is, which of the following is inconsistent with current definition of fever of unknown origin? Fever greater than or equal to 101 degree Fahrenheit on at least 2 occasions. Duration of illness more than or equal to 3 weeks. No immunocompromised state. Diagnosis uncertain despite thorough history, physical examination, and obligatory investigation. Shubham Ghai, the previous definition of FUO had categorized it into 4 types. Now we do not follow it anymore. Okay, so currently FUO is only one standard definition. The previous classification into, primarily that classification came into picture because every second case of fever in a patient with HIV, we were struggling to make a diagnosis. Because all immune markers, inflammatory markers, सब कुछ negative आता था, तो we had a classification. Now that classification is no longer practiced in the scenario of infectious diseases. Okay, so यहाँ पे कौन सा is inconsistent या सारे consistent है? So when do we call someone as having fever of unknown origin? In fact, यहाँ पे सारे statements consistent है. We call someone as having fever of unknown origin अगर उनको fever आया है 101 डिग्री फ़ारेनहाइट या उससे ज़्यादा एटलीस्ट 2 बार, और जो पेशेंट के सिम्टम ड्यूरेशन है वो 3 हफ्ते से ज़्यादा है. वाई दिस इज इनकॉर्पोरेटेड इनटू द डेफिनेशन? क्योंकि बहुत से ऐसे फीवर्स हैं जहाँ पे कभी डायग्नोसिस होता ही नहीं है, बट 5-6 days डाउन द लाइन फीवर सेटल्स ऑन इट्स ओन. तो मुझे आज 101 डिग्री फ़ारेनहाइट का बुखार है, कल भी 101 डिग्री फ़ारेनहाइट का बुखार होगा, दुनिया भर की इन्वेस्टिगेशंस आपने कर ली, फिर भी डायग्नोसिस हाथ नहीं आया है, 5-6 दिन के बाद मेरा बुखार चला गया, should I call it as fever of unknown origin? No, there are thousands of viruses that cause such infection and such fever settles on its own. तो फीवर जो 3 हफ्ते से ज़्यादा परसिस्ट कर रहा है, इस 3 हफ्ते या उससे ज़्यादा के ड्यूरेशन में एटलीस्ट 2 times पेशेंट हैड फीवर ऑफ मोर देन 101 डिग्री फ़ारेनहाइट. Patient is not immunocompromised, and we have done all the investigations listed as obligatory investigations. थोरो फिजिकल एग्जामिनेशन एंड हिस्ट्री सब कुछ किया है, तब भी डायग्नोसिस हाथ में नहीं आ रहा है, तो देन वी कॉल इट एज द फीवर ऑफ unknown origin. Okay, now how questions are constructed, they will just twist the basic terminologies. So अगर मैंने इसको चेंज कर दिया, ड्यूरेशन ऑफ इलनेस लेस देन और इक्वल टू 3 weeks, that becomes the answer. Yes, okay. Now only one point to learn here before we move to the next question, and that is, what is the investigation of choice for a patient with fever of unknown origin with no potential diagnostic clues? शुभम भाई, राइट. सी करंटली हम क्या करते हैं, इन ऑल पेशेंट्स विद फीवर ऑफ अननोन ओरिजिन, वंस इस डेफिनेशन में जो लिस्टेड पैरामीटर्स हैं वो सेटिस्फाई होते हैं, तो देन वी कॉल इट एज फीवर ऑफ अननोन ओरिजिन, एंड देन एवरी डे वी मेक एन अटेम्प्ट टू लुक फॉर पीडीसीज. द वर्ड पीडीसी रेफर्स फॉर पोटेंशियल डायग्नोस्टिक क्लू. कभी कभी ना जब सिम्टम्स स्टार्ट होते हैं तो सिर्फ बुखार हो सकता है एंड अदर सिम्टम्स मे नॉट बी एविडेंट, बट आगे जाके वो एविडेंट हो सकते हैं. जैसे कि जस्ट टू गिव यू एन एग्जांपल, समवन प्रेजेंटेड विद फीवर टुडे, वी हैव इन्वेस्टिगेटेड, लाइक वी हैव इवेल्युएटेड, 3 weeks हो गए, बार बार बुखार आया है, सारे इन्वेस्टिगेशन में कुछ निकल नहीं आ रहा है. 4th or 5th week we might start noticing that he is developing lymph nodes. Now those lymph nodes will become our potential diagnostic clue. उस lymph node की biopsy या FNA से कर सकते हैं to see what is the reason, and maybe नतीजा निकल के आएगा कि tuberculosis होगा. That is how many cases of pyrexia of unknown origin get solved. So we should be constantly looking for development of potential diagnostic clue. लेकिन बहुत बार क्या होता है कि कोई diagnostic clue नहीं मिलता है. In such cases, what is the best investigation that we can do? Kailash Giri, absolutely right. The investigation of choice for PO, if no potential diagnostic clues present, then it will be fluorodeoxyglucose PET. Yes, we will be using 18 labeled fluorodeoxyglucose PET. Why this is helpful? Because जितना टिश्यू इन्फ्लेम्ड है उतना ज़्यादा ग्लूकोज कंज्यूम करेगी. सो वी कैन आइडेंटिफाई एरियाज और टिश्यूज इन द बॉडी विच आर इन्फ्लेम्ड, एंड फ्रॉम देयर ऑनवर्ड वी कैन टेक अप फर्दर इन्वेस्टिगेशन. जस्ट टू गिव यू एग्जांपल कि हाँ, सोचो नेक में अगर कोई रीजन निकल आता है जहाँ पे इंक्रीज अपटेक ऑफ द फ्लोरोडिऑक्सीग्लूकोज हो रहा है, उसका मतलब क्या है, उस रीजन में इन्फ्लेमेशन है. एक नीडल डालो या ओपन करके बायोप्सी कर लो, यू विल हैव योर आंसर. Pratisha, absolutely right, absolutely right. Okay, now the last question. Cardiac resonance refers to. Okay, so there are 4 statements. Statement A, consolidation of a portion of lung above the pleural effusion resulting in resonant percussion note. Shubham, it is not routinely practiced in India because cryoglobulinic vasculitis or vasculitic disorders as the cause for the pyrexia of unknown origin is less common. See, there are 2 points to learn here. Our approach to a symptom or a disease depends on local statistics. So, for example, when we talk about typhoid, right, we have endemically, typhoid is endemic in India, so we have slightly higher titer cutoff for the vital test to make a diagnosis of typhoid in comparison to Western population. Right. Similarly, in India, or for that matter, most of the developing countries, the common causes for the leading causes for 2/3, 50% plus 2/3 cases of pyrexia of unknown origin are caused by infections. In the Western world, majority of the cases or most common cause for pyrexia of unknown origin is autoimmune disorders or inflammatory disorders. So that is why in them it makes sense. In India, we generally omit that step and directly go for the fluorodeoxyglucose PET, and if the PET picks up a locality for inflammation, we trace it for further investigation. The leading cause for pyrexia of unknown origin today, right now in India, is infections. Within infections, tuberculosis. Within tuberculosis, it is most likely extrapulmonary tuberculosis. Extrapulmonary tuberculosis. So in the previous question, all the 4 statements are true, but I just made a small modification. Duration of illness less than or equal to 3 weeks. Then तो आंसर यही बनेगा, ऑप्शन बी बनेगा. क्लियर? ओके. Now, question number 5, cardiac resonance. Statement number A, consolidation of a portion of lung above pleural effusion resulting in resonant percussion note. Statement number 2, prominence of sternocleidomastoid muscle on one side due to deviation of trachea to that side. Prominence of sternocleidomastoid muscle on one side due to deviation of the trachea to that side. Statement C, compensatory emphysema above the pleural effusion giving rise to hyperresonant percussion note. The rise of the level of dullness into the axilla with pleural effusion. So what should be the right answer here? Okay. So first of all, normally what happens when there is pleural effusion, fluid, let me say this is the pleural sac, we have a lung inside it. Now once the fluid starts accumulating in the pleural cavity, it will start pushing the lung up because the fluid accumulates in the most dependent part. In a standing person, right, lower portion of the pleural space will be the most dependent part. So fluid starts accumulating here. उसके वजह से क्या होगा, जो lung है that will start getting pushed upwards. The lung will start getting pushed upwards. So now lung is pushed upwards, and because of that a portion of the lung जो नीचे से ऊपर की तरफ push किया तो alveoli in that portion will get collapsed. So some amount of lung gets collapsed. This collapsed lung is what we call as because it will become solidified, we will count it as consolidation. बाकी जगह में सब अब pleural fluid accumulate हो चुका है. Okay. Now because this area is consolidated, it is not participating in the gas exchange. So a small rim of lung just above this consolidated area now starts doing overwork, means it takes more air. So when more air accumulates in the alveoli and alveoli get distended, what we call it as emphysema. So the small area becomes emphysematous. So we call it as compensatory emphysema. Why do we call it as compensatory emphysema? Because ये emphysema हो क्यों रहा है? It is a compensatory mechanism trying to do the work done by the consolidation portion of the lung. इसका जो काम है वो ये area करना चाहता है, इसलिए it is becoming swollen. So we call it as compensatory emphysema. Okay, clear. Now in this consolidated region, the few examination findings here. So when I percuss in this pleural effusion region, right, what kind of percussion note I am going to get? जहाँ पे fluid है तो percussion note क्या होगा? We learned about 3 notes, right? Resonant note, 4 notes in fact. Resonant note, woody dull, stony dull, and hyper resonant note. So normally जब air होता है तो कौन सा note मिलता है? Normal lung with normal aeration will produce the resonant note, right? Resonant note. Air ज़्यादा होता है तो it will become hyper resonant. We replace air with fluid or solidify the tissue, we get a dull note. The dull note that comes out of consolidation is usually called as woody dull note. The dull note that comes out of pleural effusion is usually called as stony dull note. This will produce stony dull note on percussion. तो यहाँ से यहाँ तक तो dull note है, right? To some extent stony, to some extent woody. लेकिन उसके ऊपर जहाँ पे compensatory emphysema है, there is more air trapped now. So when more air, what kind of percussion note I should get? Normal air, resonant. More air, hyper resonant. So I will get hyper resonant percussion note. Hyper resonant percussion note. So this hyper resonant percussion note is what we call as, okay, I will tell you. This is what we call as cardiac resonance. This is called as cardiac resonance. So whenever you have a patient with pleural effusion, जब नीचे से परकस करते ऊपर रहोगे तो डल 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 फिर सडनली हाइपर रेजोनेंट नोट मिलता है. सो दैट बेल्ट ऑफ हाइपर रेजोनेंट नोट इज व्हाट वी कॉल एज cardiac resonance. So what should be the correct answer from this question? What should be the correct answer from this question? It would be option C, the compensatory emphysema above the pleural effusion giving rise to hyper resonant note. Okay. तो सुतापा emphysema का मतलब क्या है? Dilatation of the alveoli. मोर प्रिसाइज डेफिनेशन इज इरिवर्सिबल डायलेटेशन ऑफ द अल्वियोलाई, जो ट्रू एम्फाइजेमा केसेस में अप्लाई होता है। यहाँ पे इट इज जस्ट अ कॉम्पेंसेटरी मैकेनिज्म। तो यहाँ पे डायलेटेशन इरिवर्सिबल नहीं है बट डायलेटेड है। तो यहाँ के अल्वियोलाई क्यों डायलेट हो रहे हैं? क्योंकि उनको अब ज्यादा काम करने की जरूरत है। क्यों ज्यादा काम करने की जरूरत है? क्योंकि कुछ पोर्शन ऑफ द लंग कोलैप्स हो चुका है, वो तो गैस एक्सचेंज में पार्टिसिपेट नहीं कर रहा है, तो इसका काम भी अब इस पोर्शन ऑफ द लंग को करना पड़ेगा। तो वहां पे एयर ज्यादा अल्वियोलाई में पहुंच रहा है, तो अल्वियोलाई डिस्टेंडेड है। इसी को हम कहते हैं कॉम्पेंसेटरी एम्फाइजेमा। एम्फाइजेमा का मतलब डिस्टेंडेड अल्वियोलाई। कॉम्पेंसेटरी क्यों? ये कॉम्पेंसेट कर रहा है फॉर द वर्क लॉस ऑफ कंसोलिडेटेड पोर्शन ऑफ द लंग। दैट्स इट। Nilanjana, I didn't get your point. Okay, good. So first statement one, we will not be getting a resonant note. We will be rather getting a dull note. Consolidation hota hai above the pleural effusion. We will get the dull note. Statement two, yes, right. That is trail sign. That is trail sign. Okay. Then what we call it as when the level of dullness when you are percussing is higher in the axilla and lower anteriorly and lower posteriorly. Nilanjan, what do we call this as? So statement D के लिए what's the name? Statement D के लिए what's the name? We call it as Ellis S-shaped curve. Ellis S-shaped curve. So normally when there is pleural effusion, the level of dullness is higher in the axilla, lower in the anterior region and lower in the posterior region, giving rise to an S-shaped curve. This is what we call as Ellis S-shaped curve. Okay, so that's it for today. I have one question for you to be answered in the next session, which is related to neurology. Okay, so the question is, a 45-year-old sustained stroke and was brought few months later. So the I will tell you. I'll tell you. Few months later, with behavioral issues, to a psychiatrist. To a psychiatrist. Psychiatrist noted that patient had shaved only one side of the face. One side of the face. When he was asked to copy a clock on the wall, he drew as shown below. So the patient has drawn a clock which kind of looks like this, becoming so perfect. Obviously, patient or not, humans cannot make such a perfect drawing, but I'll show you how the patient's clock looks like. Okay, so this is how a patient has drawn a clock. The question for you is to tell me what is the probable site of lesion. Probable site of lesion. So one site possible is the right frontal lobe, second left frontal lobe, third right parietal lobe, and the last one is left parietal lobe. So think about it, try to find an answer. I think Nilanjana has given you some clues for the diagnosis. So once you come back to the next session, we will discuss about localization of lesions in the rest of the brain. See, in 2 sessions of neurology, we have understood how to identify where is the damage based on patient presenting with weakness. But weakness अकेला complaint नहीं होगा neurological disorders का, right? Patients can have various other complaints. So we will be looking at different lobes of the brain, how they function, how damage to them leads to altered physiology and disease manifestations. So this is one of the question that you need to address. Okay. So with that, I'm signing off for today. So we will connect again in the next session. We will do 2 quizzes, and after that we will get back to the Reed Harrison series. Okay. And what we will do now is that from the next quiz onward, intermittently we will be having some quiz sessions. I will post the questions earlier on the PW Telegram so that you can solve them, and we will do a quick discussion, and then we will take up one topic also so that we can justify for the time. Okay. So guys, that's it today. I'll see you in the next session. Till then, bye. If I have missed any doubts, let me address. So Tapa Samantha, trail sign, I think Nilanjana had given a very like proper explanation. So trail sign refers to, in fact, it is there in the statement itself, prominence of a sternocleidomastoid muscle on one side because trachea being shifted to that side. So for example, right now just look at my neck. When my trachea gets shifted to this left side, I'm pushing the trachea to left side. Now the left sternocleidomastoid muscle becomes prominently visible. This is what we call as trail signs. The sternocleidomastoid muscle on the side where the trachea is shifted becomes more prominent. That's what we call as trail sign. So it basically indicates that the mediastinum and the trachea may be shifted to that side on which side you are seeing a prominent sternocleidomastoid muscle. Okay, so Shubham you're pretty close. So what makes you think that it should be option D? What are the logical basis behind deciding it as option D? So just address one point, whether if someone presents with what is called as hemispatial neglect, are we thinking of dominant parietal lobe lesion or non-dominant parietal lobe lesion? And the second point I want you to think is in the general population, right? What percentage of the population has the left dominance and what percentage of the population has the right dominance? So I will leave you there. I will connect in the next class. Till then, have a good day. Nilanjana, there were too many texts flowing, so I could not keep track of all of them. Okay, so see you guys in the next class. Till then, bye.